That's great. We are live on YouTube now. So we'll wait for a couple of minutes for the numbers to pick up, and then we'll start. That's great. I think it's okay to start now. Good evening, everybody. And many thanks for joining us again on the 46th iBreast Book webinar. So you'll see some of the usual suspects. You'll see the lovely Ricardo Pardo again. So we have a Spanish channel. So if you want to listen to anything in Spanish, just click on the group and go to Spanish. And you have Ash Kotari. This is a sponsored webinar by Cuptic Medical Imaging. And we're talking about margins. So the first talk, there's 4 talks, one on pathology by Trina Tramp from Denmark, one on intraoperative 3D imaging by Michael Alvarado from the USA, one on surgery by Karina Cox from England, and one on oncology by Jonas Zerdis from Sweden, to be followed by discussion. Few little things. You will have a certificate with CPD points issued in the next week. I will send it all to you. So as long as you log in for most of the webinar, you'll get that certificate. If you have any questions, please put it on the Q&A section. If you put it on the chat, it's unlikely to be picked because you can see we're already on message number 40 or 50. It's great to see many people from so many parts of the world. We'll start with the first talk. So we'll start with Trine Tram from Denmark, and Tina is going to talk about margins, and she's going to tell us about the significance of margins from pathology point of view. So Trine, the next 15 minutes are all yours.
Thank you very much. I'm very pleased to be here and very grateful for having this opportunity to talk to you about the margins seen from a pathologist point of view. So I will just share my screen here. So what we do as pathologists is that we try to bring wonderful 3D biology into a 2D section and bring this into something that we can understand and interpret. But it means that we're delivering snapshots of this wonderful biology. And though we're constantly striving to describe and quantify all the prognostic and predictive biomarkers very clearly and meticulously, what we end up is that we cannot in any way capture this completely wonderful and multifaceted tumor biology. So what we do is that we provide the best possible estimation of the tumor's true nature. But luckily, the current treatments are actually based on these estimates, and that counts also for margins. So a good histopathological evaluation of margins starts with clinical info. And it's very important for me as pathologist to have information on tumor size. Is it poorly defined, and is there calcifications in the surroundings? And in my institution, I'm very lucky because every morning we have a multidisciplinary conference where the radiologist shows me the imaging and explains to me what I'm supposed to look for. So I'm very well prepared when the surgical specimens comes during the day. I also have the great advantage that we have the possibility of taking an X-ray of the surgical specimen, which further allows me to identify calcifications. But if you do not have this in your institution, it's very important that you as surgeons convey this information to your pathologist. Clear orientation is, of course, also very important. And it's also important for me to know if you have dissected along the subcutaneous fascia, and if I'm supposed to find the deep layer of the superficial fascia on the posterior part of the specimen. And also, as you can see in this, to the right, the surgeon has stitched a re-excision to the specimen, and that is sometimes very hard to see. So that is also information that I need from you. If the specimen has been sliced or sectioned for some reason, or there's cautery artifacts, that limits the ability for me to evaluate the margins. What I like to do is evaluate margins on the fresh specimen. That gives me the best impression of the in vivo appearance of the specimen. So the flattening and pancake effect starts right from you remove the lumpectomy. And so this gives me the best possibility of seeing what it actually looked like. This is also where I get the initial impression of the margin status through inspection and palpation. And it may be quite difficult to see the tumor. And in this specimen, maybe you have noticed that it was right over here. But this is a very delicate examination with a combination of inspection and palpation. The natural borders are also easier to see on the fresh specimens, especially the deep layer of the fascia. You know that the fixation afterwards can create artifacts like shrinkage and retraction phenomena. And a margin distance that looked like 1 millimeter or maybe 2 millimeters on the fresh specimen may be completely erased, and you will think that there's actually tumor on the border if you see the fixated specimen. So according to national or local guidelines, your pathologist may not have the possibility of examining the fresh specimens, but may have to do this on the fixated specimen. Previously, we used to go to the operation room to do a perioperative margin assessment on the fresh specimen and convey the information to the surgeon right away. But because our department of pathology had to move to another hospital, we didn't have that opportunity. So 5 years ago, we turned over to doing digital imaging during surgery. But unfortunately, this led to a 4-fold increase in the re-excision rate. And that was primarily due to DCIS, presence of DCIS. And this is something that if it's not associated with calcifications, DCIS may be difficult to see on the imaging, but this is something that we as pathologists may have the possibility to see during inspection and palpation. So sometimes the tumor is very obvious, sometimes it is not. To the left, what we see here is DCIS extending right to the margin, and this has a more whitish color. And to the right, we have the tumor again. And what you may see here is that there's a tiny, tiny orange periphery around the tumor, which we can see during inspection. Palpation is also something very important. This is a lobular carcinoma that has been bisected. You see the fibroglandular tissue is kind of abruptly transversed by something, which is a lobular carcinoma. And you see here on the left side that the tissue sort of falls down from the lobular carcinoma because it has a more firm consistency. This DCIS was also during palpation, it was clearly nodular and more firm than the rest of the tissue. It is, of course, very important that we keep the orientation that you have put on the specimen, and we do that by inking the margins, and this ink we are able to see in the microscope. But there are different approaches to margin evaluation, and there's no consensus on how to evaluate margins and how many sections to process. So you can either do tangential sections, which is sort of like peeling an orange, or we can do perpendicular sections, which is more like slicing an egg. And there are advantages of both of them, but also something that goes a bit against this. So for the tangential sections, we get the advantage of examining the whole surface of the margin. But it's just, the problem is that we do not exactly know how thick is the peel. So there will be an uncertainty in measuring the actual distance from the lesion to the margin. So you very well know that the surface of a specimen is very bumpy. So if we take the outside of the peel, so to say, what we get is actually the top of the icebergs. So the section I would get is more spotty, like this one down here. But if I take the inside of the peel, what I get is a more full section, but then again, the distance may be 2 millimeters to the surface or 3 millimeters to the surface. The advantage of the perpendicular sections is that here we have the possibility of measuring the distance. You can see that here I can measure this distance or a larger distance here. But we only get representative sections of the margins in this way, and only less than 1% of the margin is actually examined. And it is very important to know which section plane you will be choosing. And you will, of course, try to choose the plane where you get the shortest distance to the margin. But this, for instance, will give you a picture like this. But if you choose this section plane, you could get a picture like this. So for the pathologist, with this wonderful complex biology, there will be an endless number of distances from tumor to margin. So the pathologist has to choose the areas with the closest distance to the margin. So, and according to guidelines, we will take the different sections and measure this. And in my institution, we only need to measure, to report and measure one distance, so the closest distance, but there may be other guidelines where you will need the reporting of 6 directions. So what we get is that we go from this perhaps 5 centimeters lumpectomy to 3 micrometer sections. So this is, of course, again, not the complete truth. This is the best possible estimate of margin status and margin distance. But what is very fortunate is that the knowledge and the evidence we have according to margin status and association with local recurrence risk, this is based on these 2D estimates. So we know that tumor on ink implies that there may be residual disease, and we know it may lead to a higher risk of local recurrence. But what we also know is that no tumor on ink does not necessarily imply there is no residual tumor. Actually, in more than half of patients with clinically unifocal tumors, they have additional tumor foci in maybe 2 centimeters away from the primary tumor. And in this section, there are actually more than 4 small lobular carcinomas. So a negative margin is not equal to no residual disease. A positive margin, which you probably know from re-excision specimens, is not necessarily equal to presence of residual disease. But a negative margin status will identify patients with limited residual disease, which will be small enough to be controlled by systemic treatment or radiotherapy. And what we see now is that with the local recurrence rate decreasing, we also see that the impact of not just margin status, but margin width is actually diminishing. And you see the differences out here in 2005 is smaller than in previous times. So to round up, I will just say a bit about margin evaluation in mastectomies. The principle is the same. We cut, we inspect, we palpate, we do the best estimate possible. But in mastectomies, we do not have any consensus on what the consequence is of positive margins, and therefore also not a consensus on reporting of a positive margin. We consider the margins in mastectomies as anatomical borders, except for the nipple base. And when you, as surgeons, do a subcutaneous mastectomy, it may be very easy to see the subcutaneous fascia, but it is actually a very delicate and not continuous structure. To the right here, you see that this very thin line is less than 1/3 of a lipocyte. So it's a really thin structure. And here you see that it's not continuous. It comes from here and it thins, and here it disappears. So my concern regarding margin evaluation and margins is in mastectomies is if we have an unintentional resection below the subcutaneous fascia level, because then we have risk of leaving residual disease. And there are evidence that there's an association between distance to the margin and increased risk of local recurrence in mastectomies, and that this also translates into impaired survival. In the majority of cases, these local recurrences are located in the skin or subcutaneous tissue, and the majority also near the primary tumor bed. So this, to me, definitely leads the attention towards the superficial margin, and I would very much like to use this opportunity also to say that I think we should, as multidisciplinary team, work to create more evidence on this problem, especially since we're seeing a lot more subcutaneous skin-sparing mastectomies. So to sum up, I want you to remember that pathology cannot describe the whole 3D truth, but leaves the best possible 2D estimates for interpretation. And the current evidence-based treatment is actually based on these 2D estimates. Please remember that a negative margin status is not equal to no residual tumor, but implies that, for instance, radiotherapy can control this residual disease. And with the hope that we can together collect evidence regarding the superficial margin status in mastectomies, especially because these patients are patients who do not necessarily get radiation therapy. So with this, I will be happy to take your questions.
That's lovely, Trina. We usually take all the questions at the end, and we'll put all the questions, but you can see that Andre Jiggren and Mats Ingevarson has already put some questions online. We will come back to that. And it was a lovely visual talk, and I like the idea. It's not the truth, it's an estimate. Now, the second talk will be, the speaker will be introduced by Ash. Ash?
So hello, everyone. And yes, the truth is best estimation, and we need to provide information as much as possible to the pathologists. And I know that Yazan has been told off by our fiery pathologist, Professor Pinder, on many occasions for not telling her that the patient had received neoadjuvant chemotherapy. So the next talk is from a good friend and colleague all the way from the University of California in San Francisco, Michael Alvarado. He's going to talk to us on the 3D imaging, and Professor Tram has already told us that she's giving you a 2D estimate of a 3D problem. So maybe Michael can tell us whether the 3D imaging could help Professor Tram give us a better estimate or more accurate estimate. So over to you, Michael.
Great. Thank you so much. Thanks, Ash. And thanks, everybody, for joining. It's truly an honor to be part of this group. So margins, why margin assessment? I think we just heard from Professor Tram about some information. Obviously, we want to decrease the positive margin for breast conserving surgery. The big issue, I think, is decreasing re-excision. Having to have the patient go back for a second surgery is always that thing that we really want to avoid. But we also want to be concerned with the cosmetic result. So there's a balance between taking out enough, not having to go back for a second surgery, and having it look nice. Patient satisfaction. Of course, there's the societal cost. So what is the cost to healthcare to have to take a large proportion of patients back to the operating room? So that costs money, time, effort, and you could open up the theater potentially for other cases if you weren't having to do re-excisions. And then, of course, those patients that decide, well, if I need a re-excision, maybe I'll just do mastectomy. And then they may start thinking about bilateral mastectomy. So the margin positivity can really have a downstream effect. So we do want to think about margins and resection and giving the best information to the pathologist for sure. The old days, as Professor Tram was showing, we would take the specimen, send it to mammography. It'd be in a plastic bag. They'd put it in the machine, and then they'd send us a picture. And we'd have no idea which way was superior, which way was lateral. And we'd ask the radiology tech, and they'd say, I don't know. We just took a picture of it. And so that was terrible. And it really caused a lot of problems with understanding what was what. Now, I will say, we as surgeons, and when we go to meetings, we spend a lot of time talking about margins. I mean, I think if I could think about what we talk about the most, margins and axillary surgery. And it seems to come up all the time. What's the best margin? How much should we take out? How are we going to get negative margins? What's your positive margin rate? And so margins are a big topic. And it's such a big topic, and there's so much effort that there is a lot of research and money going into intraoperative margin assessment. And we're talking about significant money, technology that is just going way beyond what I think we need to do. But just as a brief kind of overview of what's going on out there, I thought I'd just share a few slides. So there is spectroscopy, looking at biochemical differences between benign and malignant cells. So utilizing spectroscopy in the operating room, utilizing electrical properties or differences within the tissue for other technology. There's optical imaging in terms of extremely small microscopic ultrasound type techniques for looking at margins in the operating room. And then also, as you probably heard, molecular imaging. And this is using a dye or contrast agent, which is really kind of the, I guess I would say, Star Trek or Star Wars are really out there type of technology that we've always thought about. I mean, the perfect situation would be the surgeon does the lumpectomy, we ask for the little spray bottle, we spray it, we look to see what lights up, and we re-excise. That would be perfect, but we're not there yet. But here are some of the things that are getting a lot of investment, millions and millions of dollars. Here we have the intelligent knife or the iKnife, which uses spectroscopy. And this is in the operating room to, which seems crazy, right? Rapid evaporative ionization. So using mass spectrometry. So think about that. Millions and millions of dollars going into this type of technology to look at your margin rate or to decrease re-excision rate. And I think that's pretty amazing, but also maybe a little bit crazy. We have this called the Margin Bot, whole sample spectroscopy. So scans the entire sample using a specific type of spectroscopy to provide a representation in the gross specimen morphology. So, I mean, now we're using robotic type margin technology. This one you may have heard of probably because this is one that's actually out on the market. The margin probe, which measures local electrical properties. Seemed like it was going to be a great thing, but here you can see, again, when we start thinking about how well these things benefit us in their pivotal trial, you can see the sensitivity rate and the specificity rate. So looking at false negative, false positive, re-excision with the margin probe was 19%, re-excision with the control arm, 25%. Now, again, I think 25% is probably really high for most of us here, but you know, that reduction is not huge. Relative reduction, okay, maybe it's a 25% relative reduction, but if you're already at 6%, 7%, 8%, do you want to spend the money and time utilizing this to go from 8% to 6%? I'm not sure if it's really worth that much money. Optical imaging, again, using these high resolution microscopic imaging techniques. nonlinear microscopy, microcomputed tomography, micro CT. Again, big technology to look at margins. And you can see here, which I thought was interesting, this optical imaging system by Perimeter. And they had this abstract in December at the AACR looking at margin assessment for DCIS. Now, again, DCIS can be troublesome, but think about the amount of money and technology invested in this for a disease process, DCIS, that some people may consider a lot of times doesn't even need to be resected. So now we're spending millions of dollars on something that a lot of people think maybe we don't have to remove it. Maybe it's not as important as we thought. So finally, molecular imaging, visualizing the malignant tissue in the operating room. Again, here's a big deal. The patient actually gets an intravenous injection for a systemic drug that goes to the breast and is taken up by the cancer cells. In the operating room, you use a special light to look for the fluorescence. So that is kind of where we're getting to in terms of what I would say would be amazing. But now we have to do an IV of the drug. The drug has to be given 4 hours before, the day before. Who knows what the outcomes are with some of this? There can be anaphylaxis, and utilizing this kind of Star Trek way of visualizing. Again, millions of dollars going into this. And is it going to change it dramatically for the person who's doing breast cancer surgery? I'm not so sure. So what about if we kind of go back and think about, well, what can we do now and how well does that work? And as we were saying, we used to send it to breast imaging. And then we had 2D specimen radiograph, which gave us kind of looking in two-dimensional space, which was very helpful. It was in the operating room or next to the operating room. We could take a picture and get a sense of the peripheral margins, but it didn't give us a lot of insight into the anterior or posterior margin. And so now what we have is 3D tomosynthesis actually in the operating room with a small machine. And you can see here in our theater, it sits in the corner. We do our surgery, put it in there, and we can run it to look top to bottom, left to right, up to down. This tomosynthesis offers advantages over current radiology approach. Again, it's three-dimensional. It improves accuracy, better visualization through dense tissue. You can identify vague lesions. Images are 1 millimeter digital slices, and it really facilitates and helps with reduction of postoperative positive margins and re-excision. And we've seen that, and there's a lot of data for that. The Mozart system that we use is, again, its sensitivity is really great. The specificity reduces the amount of healthy tissue removed. And so now what you can do, instead of doing all the way around shaved margins, you can focus on which ones seem to be closest. And I'm sure Professor Tram would appreciate that in the sense that I know our pathologist, when we send them the lumpectomy, and then there are 6 margins. So not only do they have to do the lumpectomy specimen, they have to do all the margins as well. And so that's a lot of time intensity that the pathologist has to use as well. Here you can see in 2 dimensions what the surgeon sees, but in 3 dimensions, you can actually see top to bottom. And here's just some of the cases that from my institution. When you take the picture with the CubTech, the Mozart, you have the optical view, a 2-dimensional view, and then the K view, which takes the 3-dimensional and turns it into a 2D view, which is very crisp and clean. Here's kind of running it through. You can kind of see as you go from top to bottom, and you can look for your calcifications. You can look for your clip to kind of see where it is compared to anterior and posterior. So that gives you a little bit more information in terms of how to determine what may or may not need to be resected. High-grade DCIS, you can see the calcifications extremely clearly, and the K view actually gives you a little bit more information of the trail of those calcifications, as you can see here. That's the K view. Here's the standard 2D. It really shows where I want to direct my shaved margin on that inferior aspect, where the calcifications come right down to the margin. Again, here is that same case running through, and you can kind of see where the clip is and where those calcs start coming up, kind of on that anterior aspect over there. Third area that you can see here as well, again, really nice pictures with 2D versus just the standard and the K view, and then running this one as well. You can see here, the clip appears to be pretty anterior as we start. So this tells me that it's close anteriorly. And so the anterior margin is going to be something that we should look at. What's the clinical evidence? Well, there's publications for utilizing this tomosynthesis. This paper comes from a very small cancer center in Houston, Texas, also known as MD Anderson. I'm sure you've heard of it, but their data shows, again, that type of information, how well the Mozart use is the sensitivity of Mozart versus the standard exhaustive pathology. Here you can see the specificity actually outperforms their exhaustive standard pathologic assessment. So that's data there. There's also data from UT Southwestern that's been published looking at over 500 or almost 500 lumpectomies, showing that the 3D tomosynthesis really lowers the chance of a positive margin and decreases re-excision rates. And then just from our own data, when we looked at utilizing MagSeed, for example, and we use the Mozart CubTech for all of our cases, just to kind of show you what our re-excision rate is for invasive plus DCIS and pure DCIS, we're kind of hovering around the 7% range by utilizing the CubTech 3D tomosynthesis in our operating room. And here you can see where we are down here compared to some other areas in the US and around the world. So the Mozart specimen tomosynthesis system, high sensitivity, high specificity, easily used in the operating room, nice workflow. Really, are we overthinking margins? Should we just get back to the basics of having good imaging in the OR and lower our re-excision rate, and then we can redirect all of this new technology and money into something that actually really matters? So with that, I want to say thank you, and I really appreciate all of your time. I think here we're going to see a video of how this works.
This gives surgeons and radiologists a better view of the specimen anatomy and enables a reduction in positive margin rates. Three-dimensional tomosynthesis enables you to view the specimen in 1 millimeter digital slices. Each slice has its own margin. In this case, we can see a positive peripheral margin on slice 4. Each slice is created and can be viewed independently of the others. In this case, the slices above and below slice 4 have no margin involvement.
Simply place the specimen in the cabinet. Position the highest point of the specimen under the laser. This will measure specimen height. Close the door and hit Acquire 3D. With the Mozart system, you can have the confidence to know the exact location of the lesion. Here's how. Here's the standard 3D image. We can see the height of the specimen here. So we know that there will be 16 1 millimeter slices in the specimen. The slide counter can be found on the right-hand side of your screen. Each mark on the counter represents one slice. We're currently looking at slice 0, so there's nothing to see. As we scan through the slices, elements will come into and out of focus. When a microcalcification or a clip is in focus, then you know that it is within that slice. So here we can see that the biopsy marker is located in slice 2. And that the microcalcifications are located in slices 1 through 7. Very close to the anterior margin, and that the deep margins are clear. With this information, the surgeon may decide to take an additional anterior shave and that no other shaves are necessary.
Only the Mozart system uses 3D tomosynthesis to show your surgical margins as they really are. Only from CubTech.
Great. So I think we've done the promotional bit. Thanks, Michael, for a great talk as usual. And yeah, I may have heard of MD Anderson. I don't know, somewhere. It's in the US somewhere, isn't it? In a small little town somewhere. Yeah.
It's somewhere in the middle.
Somewhere in the middle. Now, it's great talk, Michael. And we come back now from across the pond back to England. And we have the lovely Karina Cox, who's one of the consultants in the southeast of England in Maidstone. And Karina is also the chair of the Clinical Standards Committee and the Association of Breast Surgery. And she's going to tell us about margins from the surgical point of view. Karina, the next 15 minutes are all yours.
Thank you. So amazing talk so far. So no pressure on me at this point. I'm just going to share my screen. Hopefully it goes smoothly. Let's have a look. Let's just. So hopefully you can all see this. I think I've actually gone to the end of the study. Hold on 1 second. So you saw my last slide, which is never a good thing. But anyway, at least you've seen a nice little doggy. Right. OK, so essentially what I'm going to talk about is actually invasive disease. So I'm going to look at management of surgical margins for invasive disease. That's because I've only got 15 minutes. And I think to cover invasive disease is enough. So I'm not really going to be looking at DCIS, pure DCIS at this point. So just a little disclosure. So I am a trustee of the Association of Breast Surgery in the UK and also chair the Clinical Practice and Standards Committee. And the reason that I'm disclosing that is pretty much everything that I'm going to talk about is based on some ongoing work that we've got in the association looking at margins. So I think that's important to share at this point. And I think those of you who managed to make it to our Belfast, to our conference in Belfast in May were treated to a very lively session on margins. And I do agree that it is the things that we talk about as surgeons, isn't it? Endlessly, margins and the axilla, year on year. So I'm not 100% sure I'm going to give you much clarity, but anyway, I'll take you on the journey that we've been on over the last couple of years. So things I'm going to cover in this talk. So talk a little bit about breast conserving surgery, factors that influence local recurrence, some existing guidance that's out there. And then also what I'm going to concentrate on is the current data and what does the data tell us? And then a little bit about future directions and some conclusions. So breast conserving surgery, well, we know it's safe. We've got 50 years of really good data to back this up, going back to Veronese's Milan 1 trial, and you've got Bernie Fisher's trial, and that is about 50 years ago, which showed no difference between essentially breast conserving surgery and radiotherapy and mastectomy in terms of long-term outcomes, although at that point there was some slight differences in local recurrence. But then more recently, you've got the EBCT-CG meta-analysis, again, no difference in local recurrence or cause mortality. And actually, as we're moving forward, we're actually seeing that actually local recurrence rates are decreasing. So over the last few years, they're decreasing. And I think that is because we've got better other treatments for breast cancer as well. It's not just the mighty surgeon cutting everything out these days. We have really good multidisciplinary teams, and things are advancing with systemic therapies, radiotherapy. So there's lots that we do which do influence local recurrence. And actually, again, there is some data which is showing as well that for perhaps breast conserving surgery and radiotherapy may even be superior to mastectomy for a lot of cases. So I think Trina really presented this really nicely, so really elegantly, that actually, breast cancer isn't just a solid tumour surrounded by nothing else. We know that tumours have micro satellites that sort of surround the main tumour that you see on your conventional imaging. And there have been lots and lots of studies which show that, if you do a mastectomy, you will find massive, lots and lots of these little tumours. But clinically, as we've seen by the data that I showed on the previous slide, it doesn't seem to make a difference. And why is that? I mean, we know radiotherapy kills cells, so it kills cancer cells, But it also has some secondary effects as well. So, you know, it will modify the tumor phenotype, and you end up releasing lots of danger signals as well, which perhaps retune the immune system as well. So, you know, there's a lot going on with radiotherapy, which does help and deal with these sort of microsatellites. So I think that's sort of a key background, really. So again, factors influencing local recurrence. So, you know, I haven't even started talking about margins yet, but we know that there are lots and lots of other things that influence local recurrence. So perhaps in younger women, younger patients, they're more likely to get local recurrence, tumor biology, so slightly higher rates in triple negative and HER2 positive, and perhaps grade 3 tumors as well. BRCA gene carriers who have breast conserving surgery will have higher risk of local recurrence. And then we know that there are other things that mitigate the higher risk. So as I've sort of mentioned briefly, chemotherapy. So we've got masses of trials showing that chemotherapy reduces local recurrence as well as systemic recurrence. You know, really good data about tamoxifen reducing local recurrence. And again, with targeted HER2 treatment as well, that not only, you know, reduces distant recurrence, but it also reduces local recurrence as well. And again, radiotherapy, and you can boost as well. So radiotherapy and boosts can also be used for people at slightly higher risk of local recurrence. But all of these things are coming together. And I think, you know, as I alluded to slightly earlier, this is probably what is responsible for our local recurrence rates, because actually as surgeons, we're going narrower and narrower and narrower on our margins, but our local recurrence rates are not getting worse. So what guidance have we got out there at the moment for margins? So in the UK, we've still got some quite old guidance from the Association of Breast Surgery, dating all the way back to 2015, which advises a 1 millimeter margin. That's around both invasive and pre-invasive disease. More recently, NICE, so the National Institute for Clinical Excellence, they produced really good guidance for early breast cancer treatment. And they give they give a sort of slightly different view on margins. They recommend 2 millimeters, but what's interesting with their guidance is that they also say that there's a bit of wiggle room if you're between sort of 0 and 2, and you can sort of take in patient factors as well. And then we've got the No Tumour on Ink Brigade. So in the UK, we haven't quite gone there yet, but certainly other parts of the world are now working on the guidance as long as there's no tumour on ink, then it's fine not to re-excise. So the UK is slightly out of step at the moment with probably the rest of the world. But now we get into the interesting bit, I think. So what does the data tell us? So up until recently, the data that's been really guiding most decisions about guidance on margins is the Husseini meta-analysis, and that was published in 2014. But something changed last year. So another meta-analysis was published last year by a British group, and they had different conclusions. So we thought in the ABS that we were very close to having our own guidance, you know, issuing some new guidance for margins for the UK. But then this new meta-analysis was published, and it's made us think again, because they have different conclusions. So the Husseini conclusions were that negative margins reduce local recurrence, but increasing the threshold does not decrease the risk. But actually the Bundred meta-analysis, so the recent one published last year, actually said that, you know, if you do have close margins, then it could increase the risk of local recurrence and even distant recurrence as well. So why were these conclusions different? So we thought we better ask somebody who knows what they're talking about. So we actually commissioned some professional analysis based at the University of Sheffield, and this was presented again at the ABS conference in Belfast. And just before I sort of plough in and talk about the actual results of our review, I think definitions are always useful. So as you can see on the screen, so positive, extensively positive, you can see the tumour right at the ink, focally positive, bits of tumour at the ink. And then what's defined as close margins is under 2 millimeters for these meta-analyses, and what is defined as negative margins is greater than 2 millimeters. So the comparison of these two studies. So Husseini really looked at local recurrence, and Bundred looked at local and distant recurrence and overall survival. Slightly, well, similar numbers of studies in both meta-analyses, but only 9 studies in both reviews. So if you look at the Husseini group, all stage 1 or 2 mostly, breast conserving surgery only, whereas in the Bundred review, they were slightly, potentially more advanced tumours going from stages 1 to 3. All had radiotherapy in the Husseini review, but only 94% had radiotherapy in the Bundred review. Follow-up was pretty similar, 4 years for Husseini and 6 years for the Bundred. And the study date range, as you can see, the Husseini review used slightly older papers, and the Bundred review used slightly newer papers, as reflected by the publication date of last year. So they did some quality assessments. There were no formal quality assessments in the Husseini review, but there were quality assessments in the Bundred review. So what really were the main differences? So they used different statistical methods. So I think that's the key thing here. So Husseini et al., they performed a meta-regression model, and they used margin positivity and margin distance as covariates. So that is assuming that these aren't linked, which again, some people might have problems with the fact whether margin's positive or not, and what the threshold is, whether it is linked or not, but that's the assumption that they made. Whereas Bundred et al., they performed subgroup analysis based on specified distances. So the results are not directly comparable, just because they use slightly different statistical methods. And again, whether the results for local recurrence are statistically significant in the Bundred review sort of depends a little bit on your sensitivity analysis. We're also slightly unclear how 1 millimetre was determined as the minimum margin in the Bundred review, but I think it was probably a pragmatic decision, because it's not clear in the actual paper how they got there, but I think it ended up being a pragmatic decision. So main findings that Husseini et al. Demonstrated that both positive and close margins are linked with increased local recurrence, but they concluded that increasing the threshold different distance was not significantly associated with reduced odds of recurrence. Bundred et al. Also demonstrated close margins as well as positive margins are associated with increased local and distant recurrence. So, you know, we thought we were going to get an answer really quickly, but you know, this is just going to go round and round and round again. So I think we need to find a balanced approach. You know, it is an emotive subject. We know that lots and lots of re-excisions causes harm, potentially, but you know, and we, you know, elderly women going back for a 0.3 millimetre margin, you know, subjecting people to more surgery. But then on the other hand as well, we do also need to be, again, this sort of pragmatic approach where people with slightly adverse tumour characteristics, you know, perhaps they do need a slightly bigger margin. I think it's going to be a nuanced approach. I love the sort of talk on Michael's talk on tech, because I think, you know, I'm an optimist. I think tech hopefully will get us out of some of this. But I also think that we probably need to get some more research on this. We need to do some proper evaluations looking at harms as well, because actually the data that these two meta-analyses are based on, it's not brilliant. So at the moment, this is the best evidence that we've got. And unfortunately, I think we're still in the area where we need to sort of think about things on a patient by patient basis. I think we're all used to dealing with uncertainty with the axilla. I think this is just going to be another sort of uncertainty. Talk to patient, just make sure that, you know, you and the patient understand the risks and benefits of each decision that you make. So apologies for not coming down firmly with a decision at this point, but I think in the ABS we're going to be thinking very carefully about this and taking this forward. So thank you very much for listening. I would like to thank especially Catherine Rigby and Professor Linda Wild for doing loads of work on this, the ABS Exec Board and the Clinical Practice and Standards Committee. Thank you.
Thank you, Karina, for sitting on the fence and not coming on one side or the other. But the dog is cute anyway, so we like the dog. Thanks again. But guys, as you know, we've been on 1 millimeter ever since I can remember, despite the papers that came out from UK. So I think we've maintained equipoise, and like you said, knowing tumor or 0.5 or 1, taking 1 millimeter more from every direction doesn't change much. So we satisfy both. That's good. So our next talk, just to show that we're truly multidisciplinary and also like to include our oncology friends, is a talk by Yanis Zedis, who is a oncologist at Karolinska. And he is going to give us a talk on the significance of margins from an oncology perspective. So over to you, Yanis.
Thank you. Thank you very much. I will try to share my screen now. Can you see my screen? Yes. Thank you very much for this invitation. I'm really happy to discuss about margins from the oncologist perspective this time. And in the next few minutes, I will try to touch upon the margins and correlation both with invasive breast cancer and also with DCIS. When it comes to invasive breast cancer, as we have heard from Dr. Fox, breast conserving surgery and survival outcomes, I will also present some data about the radiation therapy and effect of systemic therapy with focus on neoadjuvant chemo. And when it comes to DCIS, cervical excision plus the role or minus the role of radiation therapy and endocrine treatment. When it comes to invasive cancer, breast cancer and margins, we have heard, and I will not go into details since this topic has been covered by Dr. Fox, the SSO Astro guideline published in 2014 recommends the use of no Wing tumor. And thus, as we have heard from the Husami meta-analysis, it is the margin status, but not the margin width, which is associated with local recurrence in favor of negative margins. And just to touch upon the limitations that this meta-analysis had, they did not include patients with pure DCIS, patients treated with neoadjuvant treatment, and also patients with partial breast irradiation. And this was apart from the effect that margins and breast conserving surgery had on the local recurrence. We have seen this recently published meta-analysis at BMJ that the involved and close margins had also association with increased risk of distant recurrence as well. And we have heard in a really good comparison about the different methodologies. I would like to highlight here that this effect was independent of the use of post-operative radiotherapy or chemotherapy. And here, the use of chemotherapy and radiotherapy in these included trials varied a lot when it comes to chemotherapy, while the vast majority of the patients received radiation therapy. Reappraisal of existing guidelines could be discussed as previously described with a minimum clear margin of at least 1 millimeter. But again, this meta-analysis has also some considerable limitations and exclusion criteria, meaning that patients treated with neoadjuvant chemotherapy were not included, patients who underwent mastectomy not included, and patients with ductal carcinoma in situ only as well. As we have heard, there's so many factors that could affect the risk for local recurrence. And the use of radiation therapy after breast conserving surgery, as demonstrated in this EBCDCG meta-analysis, improves both the recurrence rates and the mortality rates in node-negative and node-positive patients. And better understanding of tumor biology, molecular profiling, and also the introduction of targeted therapies has made the width of margin status only one of the many factors that can govern disease recurrence. The role of boost has been also demonstrated, improving the local control rates in younger, especially in younger patients from this pivotal EORTC boost no boost trial, whereas not having effect on long-term overall survival. And when it comes to the boost and relation to margins in a subset analysis of these EORTC boost no boost trials. It has been shown that radiation boost reduced the ipsilateral breast cancer recurrence rates in patients with negative but not positive margins. And in order to further strengthen this statement, the Husami meta-analysis showed that the risk of ipsilateral breast cancer recurrence with positive margins remained high despite receipt of boost radiation therapy. And as the HSO Astro guideline concluded, the choice of whole breast radiation therapy delivery technique, fractionation, and boost dose should not be dependent on the margin width. Given that the rates of re-excision following breast cancer surgery could be approximately in 1/3 of patients, and half of them, of these re-excisions, have been performed in negative margins, there is a question if the radiation therapy plus breast conserving surgery can replace re-excision, and especially if higher dose of radiation therapy would be necessary for positive resection margin after breast conserving surgery. In this, to answer this question, there are few retrospective studies that offered boost radiation therapy in patients and showed improved local control in patients who did not undergo re-excision. A remark here would be that the positive resection margins, meaning that there was less than 1 micrometer or like focally margins and the tumor exposed margins. Of course, other indicators of the surgical status, extensive intraductal component in a tumor specimen, has no effect when margins are negative. Given the fact that the mastectomy patients that underwent mastectomy were not included in the previously described meta-analysis, I would like to briefly mention that primary mastectomy plus radiation therapy showed to reduce local recurrence rates and also mortality in node-negative patients and also in high-risk node-positive and in high-risk node-negative patients. And given that the incidence of positive margins in mastectomies is 5% and even higher in lobular carcinomas, there was an association with younger age as well, and rates of reoperation following mastectomy were also high. Therefore, additional local treatment using radiation or re-excision in positive margins could improve RFS in histologies like lobular cancers, but of course they have as a setback the low number of patients and the retrospective nature. Moving now to the effect of systemic therapy and correlation surgical margins, systemic adjuvant treatment could reduce the risk for local recurrence, but especially the use of systemic endocrine treatment does not negate the risk for ipsilateral breast cancer recurrence associated with the positive margins. And this was also observed when it comes to post-operative chemotherapy. And therefore, there was no influence when we select these treatments. Another issue that has not been touched upon and included in the previous meta-analysis is the effect of neoadjuvant treatment chemotherapy on surgical margins. In this field, there are few retrospective and heterogeneous studies which showed that high rates of negative margins and lower re-excision rates were observed following neoadjuvant chemotherapy treatment, and that no significant association of margin width was observed in terms of local regional recurrence in patients treated with breast conserving surgery following neoadjuvant chemotherapy. As a result, the local recurrence can be driven by tumor biology and disease burden rather than margin width. And based with a setback that few retrospective and heterogeneous studies have been reported, one could consider the extension of knowing on tumor indication guideline even in this population of patients treated with neoadjuvant chemotherapy. Moving to the second part and discussing the association between DCIS and margins, it is important to mention that optimizing local control in DCIS is of importance, since 50% of the local recurrences could be invasive cancers. This risk is, of course, affected by a number of factors, and one of those is the administration of systemic therapies, which of course varies when it comes to radiation therapy and also use of adjuvant endocrine treatment, which could improve local control. When it comes to margins, negative margins halve the risk of local recurrence compared to positive ones. Positive ones are considered according to the public studies as knowing on DCIS. And this comes from the EBCDCG, again, meta-analysis, that the benefit of radiation therapy after breast conserving surgery for DCIS is apparent, even in small, low-grade tumors. These studies were not designed to perform an association with margin width. The effect of whole breast radiotherapy plus breast conserving surgery was apparent regardless of the margin status, but when one looks closer to the EBCDCG data, the effect was more prominent when the margins were positive as compared to negative margins after lumpectomy. In DCIS, the 2 millimeter margin width could minimize the risk for ipsilateral breast cancer recurrence compared to smaller negative margins, and that more widely clear margins do not significantly increase the recurrence rates. Given also that the re-excision rates in DCIS after lumpectomy could be in 1/3 of patients, the ASTRO SSO guideline has summarized that the use of a 2 millimeter margin could be adequate in DCIS patients treated also with whole breast radiation therapy. When it comes to treatment with excision alone for DCIS without radiation treatment, the recurrence rates are higher compared to combination with radiation treatment, regardless of margin width, as we have seen. But here, it is still debatable the optimal margin for excision margin alone, meaning that there are other prospective studies that they have evaluated larger and wider surgical margins. Still high ipsilateral breast cancer tumor recurrence rates. The question that can be raised here after all this data and also some other upcoming data and recently published is that in which patients could we consider a de-escalation, escalation, or omit radiation therapy. And in the recently published Lancet publication from the big group in the non-low risk DCIS, there was a benefit in terms of local recurrent rates with a boost radiotherapy after whole breast radiation. And of course, new efforts are being made in order to develop different markers that could identify low or high risk subgroup of patients in order to change the recommendation for radiation therapy. One of those is the Decision RT biosignature, and also some biology-driven and microenvironment-driven markers, such as tumor-infiltrating lymphocytes, but these are only in patients with negative margins. Last but not least, the effect of endocrine treatment in DCIS, from the EBCDCG group, that tamoxifen reduces the incidence of both ipsilateral breast cancer recurrence and contralateral breast cancer risk in patients treated with whole breast radiation therapy and breast conserving surgery. And the effect on lowering these rates is higher in positive margin as compared to negative margins. However, there is no evidence to suggest an association between negative margin width and benefit of endocrine therapy. With this, I would like to thank you all for your attention, and I would like to thank especially Dr. Yazan Masanat and Dr. Andreas Karakatsanis and the whole iBreast book for the kind invitation and opportunity to discuss today. Thank you.
That's a great talk, Ines, and thank you for that. Now we'll start with a discussion. So if everybody has their camera on, there's lots of points to discuss. There's quite a few questions that Trina and others have answered. Trina and Michael and others have answered online, but we will go through some of those questions. It's great to see that there's still more than 550 people online. Remember that there are people from different parts of the world. There's people sometimes from more than 100 countries. You will have your local guidelines. You need to stick to your local guidelines. So we're not here to change your local guidelines. We're here to discuss about what we think about margins. So if you have certain guidelines that you use locally, either the ABS guidelines, or you use the ASTRO guidelines, or use the St. Gallen's guidelines, or whatever guidelines you have, you stick to that. And if you feel that there are certain things that you can change, you need to take to your MDT. And all four speakers have been very kind to Ricardo today, isn't it, Ricardo? They've been very kind to you. It's great to have you. Of course. Yes.
So you need to know why you're giving tamoxifen or an AI in DCIS. So the role is not to treat it, it's for chemoprevention. Because as shown by Yanis, there is a reduction in both DCIS recurrences and invasive recurrences, both in the ipsilateral and contralateral breast. So if you look at certain guidance, if you look at NCCN says, yes, we should discuss it with patients. If you look at NICE is sitting on the fence and saying, yes, no, maybe, but if, all those words. It's so in our MDT, we do discuss it with patients. There is a question again, if you have a mastectomy on one side, is the risk high enough to warrant chemoprevention to prevent DCIS or invasive cancer on the contralateral side? The bigger question is certain MDTs will not prescribe it to ER negative cancers, but we know that it works in both ER negative and ER positive, because not necessarily the contralateral breast cancer would be an ER negative cancer. So yes, it is definitely something that you could discuss. The problem is compliance for something which was not going to improve your overall survival, but is going to reduce your local relapse. Now, if you look at the data that comes from patients, what do they prefer? Do they prefer overall survival, or do they prefer disease-free survival? And I think there are very interesting papers that show, much contrary to our collective knowledge that we all want the patients to live longer, they want to live longer but without disease. So DFS is more important than OFS for patients. And compliance is a problem, as we know. Karina and Trina are the two women on the panel, so they'll tell us about their experience and what patients actually tell them, because we know for a fact that they actually talk more about these problems and psychosocial sexual issues with women surgeons than with men or with breast care nurses. So I'd like to hear from either one of them, their thoughts.
Exactly. If I can add, if I can add on this exactly, and this is as I showed, like it decreases the risk for ipsilateral and contralateral breast cancer, and of course, according to these two trials, is tamoxifen and NSABP 24 and NSABP B35 is so that anastrozole, the aromatase inhibitor, is better in postmenopausal women, especially in those younger than 60 years old in this case. And I agree with the discussion with the patient, but also there is a phase 3 trial that showed that even lower tamoxifen dose could work 5 versus 20.
So we have another webinar on DCIS in mid-July. So you're talking about the TAM1 study, and there will be lots of discussions on that. But Karina, do you want to say something before?
I just want to say the ABS have guidance on adjuvant endocrine treatment on the guidance platform, and we do talk about offering endocrine treatment for DCIS. I'm pretty sure. I'm just scanning through it myself now, but I'm pretty sure that we do have guidance on that. Yeah.
And if you found that, Karina, you can share it on the chat function. People can open that
Okay.
for regardless of the chat function. And Michael, you wanted to say something?
Yeah, I just wanted to reinforce what Ash said, that endocrine therapy is not a treatment for DCIS. And in my country, that's a big problem because a lot of physicians have it in their head that endocrine therapy is a treatment for DCIS. And I see so many women with DCIS that say, well, I would do breast conservation, but I don't want to take tamoxifen. And my doctor said, I have to take tamoxifen if I have a lumpectomy because that's the treatment for DCIS. And so, again, it's tricky because most of the benefit is in prevention of a new breast cancer. And so I just think we need to be able to separate that discussion with the patients. And then as you're all saying, even maybe bringing up the lower dose in the future. But really, it's one of the things drives me absolutely crazy when my patients say, oh, well, Dr. So-and-so said that I have to take the tamoxifen if I have breast conservation, which is absolutely false. So anyway, I just wanted to reinforce what Ash said.
And one comment on that also, Michael, is that here in the UK, it's a national health system, so most people have their prescription by the GP. And there was a clever study a few years ago from Dundee, where they looked at the prescriptions for patients that have breast cancer or tamoxifen and see how many patients are taking the actual prescription. And they found about nearly 50% are not taking their prescription. So the compliance with tamoxifen, it's not a great drug. It does work, but it has lots of side effects. And it's a quality of life that is very important. Ash, you want to say something?
And maybe something to do with the water up in Scotland, Yazan.
It's called whiskey.
That's what I meant, the magic water. So just to clarify with Yanis, so what is the current guidance? Do we start with 20 and de-escalate to baby tam or 5 milligrams if there's tolerance issues, or can we straight go in with 5?
Yeah, I think that the current evidence would start like with 20 and then see how it goes.
It's just because you have lots of people, like Yazan said, from different countries, so we need to make sure they understand that you start with 20 and then you go down to 5.
Yeah, I think don't change your local guidelines. You start with 20. And Trina, it was very interesting for me to know that different pathologists cut specimens differently. I realized that only when COVID hit, because we had to move the service elsewhere, and we had to cut our mastectomies to fix them before they come back to the main hospital. And I found out that some pathologists cut them like a toast of loaf up and down. Some pathologists cut it like a pita bread, side by side. And do you think that the different ways of cutting the specimen, tangential or perpendicular, will that affect the assessment of margins? For example, will a unit that have the pathologist cutting things tangentially have lower margin positivity compared to somebody that is cutting perpendicular? What do you think, Trina?
Well, actually, what the evidence says is that if you do the tangential sectioning, so you do like peeling the orange, that actually gets a higher frequency of positive margins. So in that sense, one could say that the perpendicular sections, you get a lower frequency of positive margins. And is that because you get only a representative part of the lumpectomy? I don't really know. I think this way of sampling resection margins, this is the principles are the same for every kind of specimens, whether you're dealing with lung cancer, pancreas, or whatever. It's the same principles, that what you're looking for is the best representative section that shows you the closest margins. But from the literature, we know that the tangential sections gets a higher frequency of positive margins.
Does any of the surgeons here ink their specimens in theater? So Michael does that, Karim and Ash does that, and So me, Ricardo, and Karina does not do that. I think our pathologists do not allow us to do that. But I think it is
You
more.
just don't trust you, Yazan.
Yes, so I can see the issue, Ash. I understand their point. It's
I do.
an issue rather than a specimen issue, but we know exactly where we cut it from. Doesn't it make more sense if we ink it?
Can I comment on that? Because actually, I think that makes sense. I would, when I used to go to the operating room, it was so nice that I could look the surgeon into the eyes and ask, what is this? Is this the posterior margin, or is this supposed to be a resection margin, or what? And that was really nice, because that flattening of the specimen starts right away. So I think it makes sense that you guys either ink, or you put maybe some clips, or for some way that you will be the one orienting the specimen as completely as possible.
We always put the clips, but sometimes the specimen in the big breast looks like a big sushi. So when you put the clip on the middle of it, it doesn't always represent the margin exactly you want.
No.
And then it flattens and looks funny. Michael, you wanted to say something before we go to Ash.
Yeah, I was just going to say, I do ink, but not every single case. I do the ones that I think are complex, or for the larger oncoplastic resections, and especially for large DCIS breast conservation cases, just because I worry that as Dr. Tram mentioned, the changes that happen during processing, it's not the fault of the pathologist, but I think that you can maybe get a quote positive margin that may not have been positive before the process of fixation, et cetera. So yeah.
Ash, and then we'll go to Ricardo.
So I need to be brutally honest. So we are spending a lot of money, like you said, Michael, on a new first-in-man trial using Cherenkov luminescence imaging and fluorescence autoradiography, handheld. So CLIFR trial, which is going on at Guy's. So we are inking the specimens as part of the trial, but we don't routinely do it. But what I think is also important is making a roadmap, what Michael touched on, extensive oncoplastic resections. You need to be very, very particular in drawing what you've done. And the surgeon who performs the surgery should perform the re-excision, because you may have moved tissue in such a vague way that only you know what's gone where. So if a medial margin can suddenly, let's say, if you do a superior medial pedicle and the edge of that pedicle is positive, the pedicle then goes up. So you're then looking at the superior margin, which is actually superior part of the breast, not the inferior part of the breast anymore. So you need that roadmap that you need to draw on your operative notes, and those need to be very, very precise about what tissue has been moved where, in addition to, of course, the pathologist and all the information that goes to you.
And Ricardo. So I always get every now and then a phone call from our pathologist, and when Ihab calls me, he say, Mr. Masannat, I know that there's something wrong with the specimen, and I'll end up in the pathology just to orient things. People that cannot hear Ricardo is mainly because Ricardo is jumping between the English and the Spanish channel, and sometimes when he goes in the English channel, the voice is not disappears on the Spanish channel. So apologies for that. So I shared the link for the clinical guidance platform for the Association of Breast Surgery. I think that guidance, I think it is free for non-members, Karina. Am I correct in saying that?
Yeah, I'm pretty sure anybody can access the guidance platform, and the guidance platform has got some really good stuff on it, and we're trying to update it all the time. So yeah, it's free. Yeah,
it's open, it's free, it's a great platform for people from across the world. So please check that platform. And Ash, you have your hand up?
Yeah, so I always have questions. I like to wind people up, so it's good fun. So I'm going to ask you guys a question. So Trinay does this beautiful specimen, not estimation to the best of her knowledge, and tells you that there is focal margin involvement versus gross margin involvement. Now, how many of you would actually go back for focal? How many would go back for gross, or how many of you would go back for both? So let's start with Michael, and then we can go to Karina. We'll get the view from across the pond. Since you started the problem with the margins, you need to answer.
I think you're going to hate this answer, but I think it depends on the clinical situation. So if it's an anterior focal margin or a posterior where there's maybe no more tissue to remove, then I don't go back. For a patient that's maybe 65 to 75, and it's a well-differentiated, low risk thing, I probably wouldn't go back for it. But for a lobular breast cancer or a younger woman that maybe had neoadjuvant therapy and we're not sure what the complete response was, maybe in those cases a little bit more. But that's me. But in this country, it's probably more likely that people go back for a focal positive margin, which I'm not sure that it's all that helpful. And even more important, I think, is Jose Aguilar asked a question in the chat about, and we'll talk at the next question for this will be, if you do go back, how do you even know you're in the right place to start with? So, but that's a separate question.
Karina?
I do what my pathologists tell me to do. So, we do a millimeter. So I don't think our pathologists really tell us whether it's focal or extensively involved. I mean, as long as we go back if it's under a millimeter, unless there's a real reason why we shouldn't go back. Yeah.
I don't give the information whether it's extensive or focal. But if, for instance, if it's a mastectomy, what I would add was if there is a residual disease on the ink, I would make a comment on if there's also a lot of fibroglandular tissue on the anterior margin. So, but giving any comment on whether it's focal or extensive, I don't give that. If there's DCIS, if there's invasive carcinoma on the ink, then that's what it is.
And let's remember what we're discussing is the tip of this pen. The tip of this pen is 1 millimeter. So we're discussing, is it closer than the tip of this pen or more or further away than the tip of this pen? And sometimes when you compare it to something visual, you realize, is it really that important? We still need to stick to our guidelines, but what we're arguing about is something the width of the tip of this pen. Anybody else want to comment on that?
I think I would go with what Michael said.
Can I say one thing, Ash? There's few people that have problem with the audio. The people that are not hearing us properly, just go on the English channel. Just you need to change it, choose a channel on the globe. Go on the English channel, you'll hear us okay, because there's very few people that has sent messages, and the people that are on the Spanish channel just use the Spanish channel. If you keep the globe without choosing a channel, sometimes you hear very faint voices. Sorry, Ash, for interrupting. Go on.
So just coming back to what Michael said, biology also plays a very big role, because Blake Cody very nicely said biology is king, patient selection is queen, and technical maneuvers are just prince and princesses. So I totally believe in that, because if you look at the UK small study, what is the UK small study? You're not going to get margins from there. You have an ER/PR positive tumor, 15 millimeters. We are arguing about focal margins here, but we've sanctioned a trial through ethics and MHRA, which basically says you can excise these tumors using VAB. Forget the margins. As long as it's out, you think it's out, it's out. And then you radiate them and give them, tamoxifen and everything else. So these are tumors that whether you take them out, whether you leave them in and keep them on letrozole, they're not going to make a huge difference anyway. So biology does make a difference. And like Karina said, the triple negatives and the HER2 positives. But again, now you've got pembrolizumab, you've got dual blockades, and all the trials that looked at it didn't look at that kind of that intense antibody or chemotherapy. So you are going to get a further reduction. And if you look at the EBCTG trials, which Janis mentioned, he failed to mention the one that interests all the surgeons, which is the 2017 trial, which actually showed a 5% increase in local relapse if you didn't do surgery. But if you looked at the overall survival curves, it made no difference. So again, it's all semantics that we're arguing about, but I think at the end, it's biology that's going to win the game.
Karina?
Karina, I think she pointed out really nicely in her talk also, I think, about how recurrence rates have dropped so much over the last 25 years. And because of these other therapies and paying attention to biology and treatment and such. So, I mean, if your risk of recurrence is only 3% with a no tumor on ink, and you're going to get a 30% reduction by going back, is it really necessary to go back and do that and put that patient through the second surgery? So again, I think we just have to keep things in perspective. It's not 1972 anymore. So,
Karina, you have your hand up.
Yeah, so I think Yanis came up with a really good point about, neoadjuvant systemic treatments, and the effect on margins and what that does, because we're increasingly using systemic therapy up front. So I think that will change the landscape as well, and that needs sort of a bit of long-term evaluation. So yeah, I mean, this is such a moving target, this, isn't it, really? I just can't keep up. But yeah. Yeah.
And it's now Ricardo and then Trina. And Trina, you want to say something?
Yeah, it's just a comment on the neoadjuvant chemotherapy and about the margins, because as long as we use the neoadjuvant chemotherapy for triple negative or HER2 positive tumors, I agree that we will probably see a higher frequency of negative margin status. But if we also increase the use of neoadjuvant chemotherapy for luminal cancers, which tends to regress in a more diffuse way, then we will probably see a higher frequency of positive margins, because the luminal cancers are the ones that have a very poor correlation between the clinical and imaging regression pattern and the actually pathological complete regression pattern, or pathological regression. So that again depends on the biology.
And I want to go back to Karina and Yanis. You both mentioned the Husami and the Bundred meta-analysis. What I don't get from the Bundred meta-analysis is they talk about close margins, which is less than 2 millimeters, and involved margins and clear margins more than 2 millimeters, and then the conclusion came with 1 millimeter. So, any comments about that?
Yeah. So I'm not sure, because I don't. If you read the paper, I don't know why that happened, but I think I think it was a pragmatic decision, that it's reasonable. I think they had to come down on something, but yes, the data doesn't quite lead you there. I don't know what Yanis.
Yeah, that's similar to the old melanoma. For melanoma, it was, 4 is better than 1, so we'll go with 2. So, and even that is now getting challenged, right? I mean, even in melanoma, which, before immunotherapy was this horrible disease, it's getting much better. But even there, it was a clinical margin, not even a pathologic margin. Again, we have to keep these things in context of all the cancers that are out there. We're focusing on sub-millimeter versus millimeter margins of things, when it's just, in the grand scheme of things, I think it's probably not as important. I mean, again, we're surgeons. It's like, we have to do the best we can, and it's up to us to save the patient. But probably it's less important as it used to be.
Trina, you have your hand up?
Yeah, I completely agree with you, Michael, that we have to keep the big picture here. And in the Bundred meta-analysis, I'm not quite sure, but as far as I remember, it's not stated anywhere how the pathology was done, whether we're slicing the egg or peeling the orange.
Yes. Yanis.
Yeah, it's true. I think it's. I agree both with Karina and Tina. It's like mostly since it is a meta-analysis and not individual based data, they report and they try to group the different subgroups in a way that could be comparable in order to have more power. Of course, there are some subgroup analysis there and the forest plot pointing towards the same direction. The main point is like compared to the local recurrence meta-analysis is the correlation with the distant recurrence there, which matters. And of course, I agree with all of you, and I think I've pointed out that tumor biology plays a big role.
At the end of the day, we're doing breast conservation, and of course, you look at margins for the mastectomies, and you cannot win them all. If you have very low negative margins, 0% negative margins, you're doing nearly mastectomies. You're excising most likely much more than you want to excise. There will be always discordance between the pathology size and the radiology size. And if there is no discordance between pathology size and radiology size in your unit, please let me know how you manage to do that. And you notice that the ones that have the positive margins are the ones that with a discordance of more than a centimeter, because that's what you aim for when you're doing your excision. So it's a balance between aesthetics, the amount of tissue that you're excising. If you're going to go and excise the palm of your hand for a 2 millimeter lesion anyway, then you get a negative margin, but you have disfigured so many breasts. So it's a balance at the end of the day. And we'll come on top of that, radiotherapy, like you said, Yanis, to boost or not to boost. How much benefit will we have from that boost? You don't always need to use a sledgehammer to crack a nut. You might need a little nutcracker sometimes to crack the nut, because you do more damage sometimes with all the extra treatments that you're doing. So, and that's where the MDD comes into the equation and deciding on many of those things. Karina, you have your hand up?
I just wanted to say that actually both the meta-analyses are good, you know, that they did the best they could with actually some not brilliant data. So, you know, you can't say that either one of them was a bad meta-analysis. They're both good. They came to slightly different conclusions and they did slightly different methods, but they did the best they can. And in a way, you know, will we ever get better data than we've got at the moment? I'm not sure we will. So I think what we have to do is we have to navigate through this, you know, just as we navigate the axilla. And I suspect it will come down to really nuanced decisions, individual decisions, because, you know, we'll know that some people will need a slightly bigger margin than others. Yeah, so I think it just adds to our skill set as surgeons, you know, to just discuss this really. But they are good. They were good studies, both of them.
And we're not saying that they're not good studies. They're meta-analysis, and people that do meta-analysis know how difficult is it to get to put a meta-analysis together. And if you look at the national data in the UK, if you look at the national margins audit that was led from George's by Sarah Tang and the colleagues, we had about 17% re-excision rate in 2017 when they published it. And if you look at them, they looked at the ASTRO and SSO guidelines, and they looked at the ABS guidelines. And if they changed, for example, the units that were following the ABS, if they changed them to being ASTRO or SSO guidelines, or if they changed the guidelines from the units that using the ASTRO to the ABS guidelines, the re-excision rate was roughly the same. It did not make any difference. The variation was between 15 and 17%. So whatever guidelines you follow, you still end up with some sort of a re-excision rate. It does vary if you have lots of screeners because of DCIS, but there's lots of things that we don't know really about margins. Any other comments that anybody want to mention? I think Ash had dinner, had people invited for dinner, so he had to run away. Anybody else wants to mention anything? Because there's a couple of questions that we can go through from the Q&A section that are excellent questions, really. So there is no questions. I see Andre Jubilan, and I think Michael has answered that, and also Trina has answered that. Now, frozen section. What's your thoughts about frozen section, Trina?
Well, one has to know that frozen section leaves you with a poorer morphology than the final section. So it creates some artifacts. So it's only it's an estimate. So I don't think really that there's a need for frozen section. If you see invasive carcinoma, you can use it. If you see DCIS, you can use it positively. But if you don't see anything, Well, it doesn't mean that you do not need to go back to do a re-excision when you get the final results. So I wouldn't waste time and money on doing frozen sections. I have to say that. And someone asked a question about sentinel nodes and frozen section and sentinel nodes as well. So I'll just comment on that briefly. We stopped doing frozen sections on sentinel nodes years ago, because what happened was that the patients were actually just lying in the operating room. And then we came back and said, well, there's some macrometastasis. And then they were randomized in the Scandinavian trial, Xenomac, to radiotherapy towards the axilla or axillary dissection. So half of them were just lying in the operating room waiting for nothing. So we stopped doing the frozen sections, and I think that's a good solution. So frozen section, that's that I wouldn't waste the money.
And we will not have access to frozen section where I work. I barely get it for the nipple. Sometimes when we do skin nipple sparing mastectomies. But if I ask for frozen section for margins, I think I'll be in trouble. I'll be sacked. Do you have access? Anybody else has access to frozen section that I know? No, I don't think it's very easy. But I know that people that have access to frozen section, they might have lower excision rates. And that was a comment from Andrei Zhigulin, who's one of the senior surgeons in Ukraine. And thank you, Andrei, for joining in again. There are a few other things that we want to talk about in margins. Mainly people will talk about lobular cancer and lobular cancerization of the nipple, especially if you're doing nipple skin sparing mastectomies. I think if there's anything involved, it's very easy to go back and excise the nipple. Does anybody find it? I'm sure that Karina, Ricardo, and Michael, any comments about that? If you have positive margin for a nipple, you know exactly what to take. You don't need to remove the whole areola. I don't agree with removing the whole areola. Some areolas are very big, but if it's central focal in the nipple, the nipples are usually quite insensate after the mastectomies. It's not difficult to remove the nipple. Any comment about that, Michael or Karina?
I would, we don't do frozen sections on sort of under the nipple if I do a nipple sparing. I must admit, if it comes out positive, the whole nipple goes for me, really.
Michael?
Yeah.
Yeah, so I probably hardly ever have had to remove the nipple. I think, as you all know, I mean, we do when we say nipple sparing, it's really coring out all of the breast tissue from behind the nipple. And it's very rare to have a positive margin or anything abnormal there. But I agree with you, in the cases where there were questionable DCIS at the margin or something at the margin, you can go back. There's always a little bit more you can take and save the nipple areolar complex and prove that there's nothing there. The other thing that we do sometimes is I'll do my nipple sparing mastectomy, and then I'll send, it would be similar to a shaved margin, but then I'll take the last little bit in the nipple itself and send that as the final nipple margin. But yeah, we rarely have positive margins for that. And so I think, we try to do everything we can to try to save that for the better cosmesis.
And for us, usually anterior margin and posterior margins are not relevant as long as you have been in the correct plane, because some people are asking about anterior margin, posterior margin. So if you've removed everything down to fascia or been in the correct subcutaneous plane, even if they're close, then I wouldn't go back for an anterior or posterior margin, but you go back.
I will say, real quick, I will say this, and again, this is one of those kind of kooky, crazy things that we do, probably to treat myself or the pathology report. But a lot of times when I do mastectomies, I will take this kind of small shaved margin on the anterior surface and right over where the tumor was as a separate piece that says anterior margin over tumor, to prove that there's nothing there, there's no breast tissue there, it's just fatty tissue. I know it's silly, but I think it makes the patient feel better. It definitely makes the radiation oncologist feel better, because any chance to radiate, they're in there, so So I think that can be beneficial at times as well.
Any comment on that, Trina? You have your hand up.
Yeah, I'm just wondering, Michael, why do you send it as a separate piece? Why don't you just include it in the mastectomy? So it's over the tumor from the beginning.
Yeah, it's basically a mastectomy in the correct plane, knowing that there's nothing left. So I'm sure there's nothing left. And so if it came back positive, I would feel comfortable that there's nothing left. But sometimes patients have it in their head, the radiation oncologist has it in their head, the medical oncologist, like, are you sure? And so, it just causes so much confusion or whatever. So it's really just to make everybody realize that, oh yeah, of course. And it's not that I left something and now I'm taking more. It's just literally there was nothing left, but it's just some fat lobules to prove that there was nothing there. But you're right. It is, like I said, I'm not treating, it's not like I'm doing anything medically beneficial. It's psychologically beneficial and anti-anxiety beneficial.
And people are asking, do you take the fascia on the muscle? I don't usually excise the fascia if the tumor is far away. Does anybody excise the fascia here from the surgeons? No.
We do. I mean, that's just the way we were trained,
And Ricardo, you have your hand up. That's great. And I think there's always a question when, like Ash mentioned earlier, if you have a positive margin, you should go back and excise the margin yourself because you know what you've done in the breast. Sometimes remember that 50% or less of the positive margins, even the involved margins, when you do the re-excision, they're negative. Are they negative because they're purely negative, or are they negative because you've taken the wrong bit? That's something that you cannot be 100% sure of, but that's why we have people like Yanis that zaps everything with the radiotherapy and clear all those margins for us. Any final comments by anybody, because it's nearly reaching 6:45? That's great. So first of all, for people that are attending, thank you for staying. We still have 440 participants online. The next webinar is in 2 weeks' time. We have updates on conferences. So we have Prof. John Benson from Cambridge talking about San Antonio. We have Michael Gelland from Vienna talking about St. Gallen's. And we have Ramzi Katris from the UK talking about the ABS. And we'll have a lovely discussion after that. Then we're planning a DCIS webinar in mid-July. Please remember we have a little course in Aberdeen. If anybody is interested, we have a great faculty to include Mustafa Hamdi, to include Alberto Rancati, Giuseppe Catanuto, Nicola Rocco, Andreas Carcazzanes. So we have lots of people from different parts of the world, from Argentina, and also we have Farid Mahboudi coming all the way from Australia, with many surgeons coming from the UK, including the lovely Ricardo Pardo and Ash Kotari, and we have quite lots of people coming. I think the faculty is about 15 very experienced surgeons. There's 2 courses. One is a lecture-based one, only for 2 days. That's only £250. And that's the only one that has still spaces left. The cadaveric course has been fully booked for a few weeks now. But we'd love to see as many of you here in Aberdeen if you can. If you can, then we'll try it for next year. Now, many thanks for the faculty, many thanks for the panelists and speakers for giving up your time on a Saturday evening, and many thanks for everybody that has logged in from the different parts of the world. So for people in the States and South America, have a lovely day. For people in Europe and the Middle East, have a good evening. And for people in the subcontinent and further east, have a good night and sometimes early morning. Thank you, everybody. Thank you.
Thank you.
Thank you.